Hi, everyone. Hello, and welcome to the webinar on opioid misuse and addiction for community health workers. I'm Deb Kazmierzak, and I'm with the Iowa Chronic Care Consortium, which is a nonprofit organization dedicated to advancing the skills of the healthcare community to reduce the burden of chronic disease and improve the health of populations. This is the first of 4 webinars we are pleased to offer that are focused on providing information about specific health topics. The goal of these webinars is to arm participants with some basic information about specific health conditions so that you're able to serve those clients or patients you work with more effectively. To bring you this series, we've partnered with the Midwestern Public Health Training Center housed within the University of Iowa and 2 very talented graduate students. Before turning this over to our presenter, I wanted to talk a bit about our target audience. You'll hear the speaker talk a lot about community health workers. We use this as an umbrella term that encompasses a broad spectrum of roles. Many people in these kinds of roles have different job titles, such as case manager, navigator, care coordinator, or outreach worker, to name a few. But these roles generally fall under the umbrella term of community health worker, or CHWs is the acronym we often use. So there are CHWs that work in hospitals, primary and specialty practices, as well as CHWs who are out in the community located in faith-based, residential, or community-based organizations that serve clients or patients with a variety of needs and offering a range of services. A CHW might be responsible for outreach to those experiencing homelessness, refugees or new immigrants, those struggling with substance abuse issues, chronic diseases, poverty, domestic violence, and the list goes on. So while you'll hear that community health workers or CHW repeatedly through this webinar, if your role fits under that sort of umbrella term that I described, we're talking to you and hope you find value in this information. With this background, I'm excited to introduce our speaker. As you know, this webinar is focused on opioid misuse and addiction, which I'm sure you know is a crisis in our nation now. As I mentioned, there are 3 additional webinars focusing on obesity, which is Monday, November 13th. Diabetes is Friday, December 1st. Depression is Monday, December 11th. We hope you'll tune in to all 4. And now I'm pleased to introduce our speaker, Patrick Dowd. Patrick has worked as a direct support professional in the state of Iowa and is currently a master's candidate at the University of Iowa College of Public Health. While providing services for individuals with chronic illnesses and substance abuse disorders, Patrick became interested in bridging the gap between research and practice in order to connect health information with community figures who are in the best position to use it. He's also worked on the front lines of the opioid crisis, providing trainings and support in areas impacted by opioid use. Patrick has done an outstanding job in distilling a lot of information into this brief webinar for you in what we hope is an easy to understand and follow format. So Patrick, take it away.
Thank you, Deb, for that introduction. And again, welcome everyone to this webinar on opioid misuse and addiction strategies for community health workers. Before we get started, I'd really just like to thank everyone for your interest in this topic. I know that this is an issue that is close to a lot of people's hearts as we see more and more lives touched by addiction in this country. It's also a topic that's changing really quickly, both in the public eye and in the medical field. And even in the last couple of weeks, it's been something that's been in the news a lot as it's being talked about now as a public health emergency by the president. I think that community health workers will play a really important role in bridging that gap between healthcare and the public. So again, thank you for your interest and thank you for turning out. To run through the goals a little bit for this webinar, by the end, hopefully we're going to understand what opioids are and how they are impacting Iowans. And for those of you who are maybe tuning in from outside of Iowa, don't worry too much. I think that a lot of this information will be generalizable. So don't worry too much about that. Also, we're going to explore the environmental factors contributing to opioid misuse. Hopefully we'll be able to recognize signs of opioid misuse and addiction. We're going to learn skills that can help us protect the safety of those struggling with opioid addiction. So before talking a little bit about the substances that we typically think about when we're discussing opioids, I think that it's good to have a little bit of a background on the body's natural opioid system. So every person's central nervous system naturally produces chemicals called opioid peptides, which are released during certain activities the brain's trying to promote. So think of activities like exercise or eating or socializing. Those are exactly the type of activities that might cause opioids to be released in the brain. And when they are released, and when they attach to structures called opioid receptors, which sole purpose is to receive those opioids, they produce a few pretty distinctive effects. So one of them is that they suppress pain. They do a great job of sort of naturally suppressing pain. They also slow our breathing down a little bit. So the respiratory depression is something that we talk a lot about. It slows the breathing, and it also produces this sense of calm or euphoria. And on the right, you see an example of one of the body's natural opioids that you might have heard of. It's called endorphins. And when you hear about someone who's maybe hooked on exercise or really, really enjoys exercise, just doesn't really feel themselves unless they do their workout, it might be someone who's enjoying the benefits of the natural opioid system and sort of enjoying these endorphins. So that opioid system plays a key role in how the body promotes certain behaviors and how it manages pain. But typically, when we're thinking about opioids, we're not so much thinking about those natural opioids as much as we're thinking about the drugs that people use. So the substances that we call opioids are called that because they act on those same receptors in the brain that natural opioids use. So those same parts of the brain that make us feel good when we exercise or when we socialize, those are being activated by the drugs, opioids. So in a medical context, they're trying to mimic some of the positive things that the body is already doing, which is why they're still so commonly prescribed for pain, because naturally opioids are used in the brain to suppress pain. However, because they produce a much stronger effect than natural opioids, they're also highly addictive. So here we have a partial list of some of the most commonly used opioids. As an aside, you might hear people talking about opioids and sometimes talking about opiates. The difference between those terms is that opiates are substances that are derived directly from the opioid poppy plant that we saw in that previous slide, while opioids are just any substance that binds to opioid receptors in the brain. So that could be something that's synthesized in a laboratory. It doesn't have to actually have anything to do with the poppy itself. So here on this list, we have hydrocodone and oxycodone, which are two medications that have really exploded on the market as common pain medications that are prescribed an awful lot. One of the things that's distinctive about them is they were sort of marketed as the 12-hour relief. So these long-acting medications that provide relief for a long period of time. It's been sort of disputed whether or not it is really 12 hours, it's sort of patient to patient, but that is how they were marketed. We also have Percocet and Vicodin. Those are very close to hydrocodone and oxycodone, respectively. The difference is that they are mixed in with acetaminophen, which is just Tylenol. So it actually produces a stronger effect because they also have the Tylenol mixed in there. Additionally, morphine, not so commonly prescribed outside of the hospital, although it still is, but really pretty common in maybe a post-surgery situation, used for pain relief, for acute pain, and it's a strong opioid. Additionally, we have codeine, which is actually worldwide is one of the most commonly used opioids because it's in cough medicines still. It's only about 1/10 of the strength of morphine, so it's a little bit less potent than some of these other opioids on here. And we have fentanyl, which I have a little star next to that because while it is a prescription pain reliever, it's commonly prescribed in the form of a patch or a spray, it's also produced illegally pretty frequently and mixed in with heroin. And you probably heard in the news about fentanyl being a huge factor in a number of overdoses. And under illicit opioids, the main one that we talk about is heroin. And what sort of distinguishes heroin from some of these prescription pain relievers is that it usually comes in this powder form, which is mixed with a variety of things. But what's key to know is that we don't always know the potency. It can be a little bit tricky to sort of predict how much a shot of heroin is going to be for somebody. So again, it's sort of variable potency that makes it a little bit more dangerous and a little bit more addictive to a number of people. And then finally, we have maintenance medications like methadone. We're going to really dig into those and talk a little bit more about methadone and some other maintenance medications, but they're usually prescribed for people with opioid use disorders to help them sort of wean off and sort of deal with some of the effects of opioid addiction while they're trying to get sober. So as I mentioned earlier, opioids are known to be habit forming, especially when they're used without directions from the provider or differently than the prescription from the provider. But there are a few features of opioids that make them perhaps a little more difficult to quit than even some other addictive substances. And the important thing to remember with that is that they create long-term changes to chemical balances in the brain, which can make recovery pretty difficult. So overall, there are three basic components of opioid addiction. We have this overwhelming psychological desire to use opioids. We have an increased tolerance to opioids, and we have withdrawal symptoms when opioids are unavailable. We're going to dig in a little bit to each of those. So this might seem a little bit obvious, but the first key feature of opioid addiction is that people who are addicted will seek out opioids. But not only that, they will seek out opioids at great risk to other areas of their lives. You'll see people that are risking their jobs or their relationships to find opioids. And this kind of behavior can be pretty baffling to the outside eye when we're seeing a client who's just sort of seems to be sabotaging their life in order to seek opioids. But it makes a little bit more sense when we consider the ways that opioids change the brain. So when someone uses opioids, their brain releases a huge influx of a chemical called dopamine. And that's what we're seeing on this figure over on the right, is a dopamine release after using opioids. So dopamine is commonly associated with these feelings of happiness and pleasure, and the brain uses it as sort of a roadmap to find rewarding behaviors. But when a person uses opioids, the influx of dopamine is so high that the brain reacts sort of to say, okay, something's wrong here. There's no way that a normal behavior is supposed to produce this much dopamine. Something's up. So what the brain does is it tries to correct what's wrong. And it can do this in a couple of different ways. And one is to just produce less dopamine in general. So if it does that, then the person's baseline mood suddenly sort of collapses and goes down a little bit. So suddenly they're a little bit irritable all the time. And that's if they've been using for a short amount of time. But really, if they've been using a little bit more, then suddenly their baseline mood just collapses and they're just feeling awful and they're not really able to function. And at the same time, they're remembering this other activity that they remember, okay, I think I remember this thing that I did that made me feel better, and it's using opioids. And so suddenly you have people, they're craving drugs, not because they want to get high, because they just want to feel normal. So that's what a lot of people do. They go back to the opioids to feel normal. But there's another problem now. And it's that in trying to correct that chemical imbalance, the brain also is less sensitive to the opioids now. So it requires more of the substance. They have a higher tolerance. So even if a person wants to feel normal, they need to keep increasing their dose to do so over and over again. So suddenly they're needing more than their initial dose just to feel normal. You can see that over on the right here again. We have sort of depicting how morphine injection produces a little bit less of the effect each time that someone uses it as they build up tolerance to the substance. And finally, we have something that folks might be a little bit more familiar, which is withdrawal symptoms. I think that people can often sort of sympathize a little bit more with the withdrawal symptoms than maybe some of the other symptoms of opioid misuse, because everyone's had the flu or everyone has had a stomach bug that's made them feel terrible. And that's what withdrawal symptoms look like a lot of the times. There's vomiting involved, there's shaking, there's aching all over. But really, it's important to remember that this withdrawal is really only part of the story. It's that it's a multi-step process that sort of hijacks a person's brain by reshaping their reward system. So you can see over here, we have a depiction of the opioid withdrawal timeline, sort of showing this whole process starting out with some acute sickness like vomiting and then sweating, and then sort of these anxiety and paranoia that happens with opioid withdrawal. And then we sort of see them subside a little bit within a week or 72 hours or so. One issue I would take with that is that all the full symptoms of opioid addiction aren't gone in a week. So they still have a lot of those effects in the brain that's changed the reward system. So people will still be craving long after. For a long time, they could be craving for well over a year after they've stopped using. So outside of these symptoms of addiction, opioids can have some other pretty negative effects on the body. It can cause some problems with digestion. Constipation is a classic symptom of anyone with opioids. It's really, really common, even if they're just using as prescribed. Lots of digestive problems. A lot of the other symptoms are sort of tied up with how much someone's using and how they're using, whether they're snorting the drug or if they're injecting it or if they're just taking pills. That'll have an effect on some of these acute symptoms. But out of all these symptoms, the one that we're most concerned with oftentimes is this high risk of overdose. So as the brain builds up that tolerance, it actually builds up a tolerance to the psychological reward and the dopamine effects a little bit faster than it builds up the response to the suppressed breathing. So when they're taking more and more, it's still causing their breathing to slow. So when we talk about an opioid overdose, we're talking about someone who's stopping breathing. Their heart doesn't stop or anything initially. What happens is that they're not breathing. And once we get into injecting opioids, that introduces a whole new group of risks that are mostly associated with sharing or reusing injection equipment. Sharing needles leads to blood-to-blood contact, which is how HIV is spread. So it puts you at risk for contracting HIV. Hepatitis C virus is a liver disease that's extremely common in people who inject drugs. Over 60% of hepatitis C infections actually occur due to injection drug use. And unlike HIV, the hepatitis C virus can stay alive outside of the host for about 3 weeks. So that makes it really dangerous. So even if you're using something that's been sitting around for a while, an old cooker or something like that, to use for injection, if the client's using something like that, the hepatitis C virus could still be alive and can still be easily transmitted. It also introduces bacteria into the body. So that's when we're talking about these skin infections and these abscesses. And if that bacteria moves through the veins and reaches a vulnerable area of the heart, it could even cause endocarditis, which is bacteria in chambers of the heart. So many risks with injection drug use that aren't necessarily present for people who are using a different route of administration. So to put some of this information into the context of what's happening today, public perception of addiction is changing really, really quickly. For a lot of our country's history, drug use has been seen as something we sort of sought to remedy by punishing people. It's been seen as maybe a criminal justice problem or something like that. And additionally, drug use has often been seen as something that happens in inner cities. It happens to people of color, people who have typically been policed a little bit more harshly. Now we're seeing this problem that, first of all, it's kind of grown out of the healthcare system. And second of all, it's something that's really hitting all populations. So we're seeing in rural areas, in urban areas, in people of color, in white people, really just across a number of populations. And in terms of the numbers behind the epidemic, it's pretty alarming. Drug overdose is now the leading cause of accidental death in the United States. It's overtaken car accidents for the last several years. So really, really prominent cause of death, especially in younger people. Additionally, drug overdoses themselves have more than doubled since 2002. And that's drug overdoses overall. So that opioids have actually increased even faster than that figure would lead you to believe. And also, opioids are involved in more than 3 out of 5 drug overdoses. So making up the majority now is whether it's prescription opioids or heroin or fentanyl, something like that. And over on the right, I just have, I'm sure people have seen plenty like this, but some examples of news stories from the Des Moines Register that they reported from across the country of these really a lot of clusters of deaths. You can see 10 hours, 15 overdoses, and also some other more chronic issues, opioid epidemic increasingly reaching newborn babies. You can see there. That's also a big concern. And it's worth mentioning just that it's no coincidence that painkiller deaths have gone up at the same rate as painkiller sales. We see them going up really in tandem and sort of rising and dipping at similar times. So definitely a big connection there. So one question that a lot of people have is, where are people actually getting these drugs? And one answer is, like the slide before that would sort of lead you to believe, that doctors are prescribing these drugs in high quantities, like we saw in that chart. But what we're learning is that it's actually a lot more complex than that. So a high proportion of people who go on to actually develop problems with opioid addiction are getting them from family and friends. So you can see 75% of opioid misuse begins with using drugs that are not prescribed to that individual. So when we're thinking, well, why can't we just sort of police these people who are getting these dangerous drugs out on the streets? How can we sort of punish people who are misusing opioids that they get from the doctor and passing them on? Well, it's a little bit more complicated than that. We're not really seeing a typical situation. We're seeing a lot of it is casual transactions between people who are really familiar with each other. And just sort of traditional policing is a little bit complicated by that fact. To tie this to Iowa, Iowa doesn't lead the country in opioid prescriptions or overdoses, but we have seen a big rise, like the rest of the country, both prescriptions and overdoses. And in recent years, we're starting to see something in Iowa. We're starting to see heroin overdoses, which have traditionally been really extremely uncommon in Iowa. And even though they're still relatively uncommon, it's alarming how fast they're increasing. So this next slide sort of shows that. We see these OPR stands for opioid pain relievers. And so we see these opioid pain reliever deaths climbing and climbing, and then actually dipping down a little bit, which is encouraging. it's because of, well, potentially because of a prescription drug monitoring program. So they're starting to have a little bit more oversight on how many opioids are being prescribed to people. But then what we see at the bottom line there is those illicit opioid deaths like heroin or fentanyl. And those are starting to climb a little bit. We can see that they're still low. Maybe it might be something like 50 a year or so. So still pretty low, but climbing really, really quickly, sort of doubling over a couple of years' time. And so that is definitely something to keep an eye on in Iowa. So I hope that some of this information is helpful in showing some of the ways that opioids affect the brain and some of the ways that the medical field has contributed to the current epidemic. However, I think that even with that information, it can be a little bit hard to understand why people choose to start using opioids in the first place, especially when they're hearing about all these deaths and all these negative effects in their communities. And answering that question isn't easy. Even for the people who use themselves, it can be really hard to sort of pinpoint exactly why they started using. But ultimately, I think it's really important to remember that our choices are constantly interacting with our environment, and that the quality of options is always going to affect the decisions that we make. So answering this question, but each person chooses to start using drugs, right? We have to look at environments in order to answer that question. So a lot of times when we are answering that question, we talk about these environmental settings as the social determinants of health, since they play such a big role in determining our health behavior. So different aspects of the environment play roles in whether or not people make choices that may ultimately harm their health, like using opioids. And moving ahead a little bit, this is one way of sort of visualizing that. It says this big sort of cycle with different features of the environment affecting others. So we can see something like economic stability is going to affect your ability to participate in your education, and your social and community context is going to affect the quality of your healthcare options. So all these sort of different environmental factors interacting with one another and then producing outcomes. Another way of looking at it is as more of a nested system where there are different levels of the environment that affect people's lives. So for instance, you might live somewhere where there's few economic opportunities and high availability of opioids. Your friends and your families are using opioids casually, and it's a big part of social life. But if it is a big part of social life and you're also suffering from an untreated mental health problem, then you're ultimately going to be a lot more vulnerable to using opioids. So you have these sort of individual factors, things that I labeled over here like genetic predisposition or age or mental health conditions. And those are only part of the story. You also have these much bigger community factors, these societal factors, these sort of laws surrounding substances, and cultural norms and stigma. And all those together are all sort of contributing to whether or not people are using these drugs. So opioid misuse in rural areas has been growing in particular. And there's been a lot of research into why, and that research is sort of focused on these social determinants of health. I wanted to delve a little bit into some of these factors, not just because of the fact that Iowa has this large rural population, but also because I believe that we see a lot of these factors in cities as well, cities that I've seen, and they aren't just unique to small towns. And one of these social determinants is clearly healthcare. Rural areas often have fewer primary care providers and specialists, for that matter. And that can put a pretty big strain on the healthcare system and put a lot of pressure on physicians to treat people with pain, especially in these sort of aging communities with a lot of older people. And so statistically, opioids are prescribed more commonly in rural areas per capita. So a person is more likely to get opioids prescribed to them if they're living in a rural area. And on the social side, people like to sort of joke around that everybody knows everybody in these rural areas. And I think that there's some truth to that. And I also think there are lots of good things about that. There are close communities of people who are looking out for one another, and that's really good. But one thing that we've sort of had to grapple with the opioid crisis is that these close, tight-knit communities also allow for drugs to spread really easily. So we see the out-migration of young adults. So we see these young adults who are deciding to go to a city for college, or maybe they're deciding to go to a city because the job options are better. And so they're sort of leaving behind an age gap of a lot of sort of younger people and some really considerably older people that are spending some time together. And that sort of allows for an opportunity for drugs to get distributed from these people who are more likely to be prescribed and then these younger people. Additionally, this has been talked about quite a bit. The economic context, it's also quite significant. It's true that opioid addiction is a problem across a number of income brackets. So there are rich people who use opioids, there are poor people who use opioids. But being unemployed is a serious risk factor, especially for overdose. And sort of these lack of job opportunities in a community can really predispose it to having problems with opioid misuse. So in the case of people who are arrested too, and they're trying to recover afterwards, if they're arrested for a, a crime related to their drug use, it can be even harder to get a job. So a lot of places will ask for a criminal background check, and they won't hire people with a record. And another social determinant is the environment that someone grew up with. So I don't want to generalize too much here about childhood instability and trauma, but it is associated with certain substance use behaviors, including opioids. So not every person who uses drugs has had an experience with trauma, should be labeled that way, but it is something to definitely consider. If someone's had a really hard childhood, then a lot of times a coping mechanism can be substance use. So to give a little bit of an overview, we have these communities with limited economic options and lots of opioids due to inadequate treatment options, whether it's having too few primary care providers or having many, many people with chronic pain. And the opioids are being shared across lines of age and spread throughout these really tight-knit social networks. And those who do ultimately become addicted, they don't have too many choices for entering treatment. A lot of times, rural areas don't have so many treatment options, whether it's inpatient or outpatient. And again, this doesn't tell the story of every community struggling with opioid addiction. As community health workers, I'm sure a lot of you have insight into the social determinants that are active in your particular community. But I hope that does illustrate how some of these systems and outside situations can play such an important role in the lives of individuals. So that was focusing more on sort of the diffusion of opioids, sort of sharing amongst people that weren't prescribed opioids. But the part of the story I don't really want to leave out is people who do get them from their doctor initially and do become addicted. So this is a story from Colorado of a woman named Melissa who shared her story. Melissa was prescribed Percocet, very powerful opioid, following a cesarean section. And the pills helped with the pain. And so she began going to urgent care doctors who prescribed opioids leniently. There wasn't much oversight in the form of a monitoring system. The pills became too expensive, like they often do, and she felt hooked. So began using heroin and selling drugs to support her habit. That's something that we do see in a lot of people who are economically challenged, and then they're hooked, and they are going to look for the cheapest option, which is oftentimes heroin. And then they're in these social groups of people who are selling drugs. And then when she finally did decide she wanted to enter treatment, the only facility is 2 hours from her home and has a 6-month wait list for MIT, which is a kind of treatment that a lot of opioid users prefer. So that gives an idea of sort of some of the many, many barriers that happen for people once they do start using opioids prescribed by their doctor. Another thing that I don't want to just leave out is stigma. So stigma occurs when societal attitudes about a condition negatively impact how people view individuals with that condition. It's often really difficult to even talk about needing help for a substance abuse disorder. So decades and decades of negative media about drug users has definitely contributed to how people look at those people and them being stigmatized. Stigma helps explain why so few people actually do seek out treatment. This is an estimation of that only 11%, excuse me, 11% of adults with substance use disorder receive specialized treatment in 2014. So that's just a huge portion of people who aren't seeking out treatment. And stigma is one reason. And this was an example that I just thought was pretty fascinating from a study that I saw. And that was, it doesn't just affect everyday ordinary people, it affects clinicians. So in one study, clinicians were asked to describe whether a person needed more treatment or more punishment. So they might ask, well, does this person need to be sort of put on probation and have a probation officer, or does this person need to enter a treatment facility and get a medical response? And so one of these groups of clinicians, these are doctors, were given a scenario where the person was described as a substance abuser, while the other group heard the same exact scenario about a person with a substance use disorder. And so this group of doctors hearing about the substance abuser were more likely to say that they should be put on probation. They should get sort of a punishment style treat rather than treatment. And I just thought that was really interesting, and just how we talk about it has such a big impact on decisions that are made about these people's lives. So the formal healthcare system has in recent years really failed in a lot of ways to prevent the negative effects of opioids, in part because they don't always see the social determinants of health and how these environments really play into the choices that patients make. Community health workers, on the other hand, do see these social determinants every single day with their clients. They see the things that affect their lives. So I think that community health workers are in a really unique, great position to address some of these social determinants. And I've outlined a few ways that I think that they can do this. One is just to recognize opioid misuse in its early stages. Oftentimes people, they just get a little too far into it before they are recognized, even by friends and family, that something is going wrong. Additionally, we can help clients navigate this extremely complex treatment system. It can be really hard if you're battling your addiction and at the same trying to make these tough decisions about treatment. And community health workers can help with that. We can break from the societal stigma by being a non-judgmental source of support. And finally, we can know how to reduce harm amongst people struggling with opioid abuse. So there are a few ways that community health workers can recognize opioid misuse in its really early stages. And some of these are a little tough because they're on opposite ends of the spectrum. So we see things like noticeable excitement or euphoria. Someone's not really acting themselves in a kind of a positive way. They're in a really good mood, or they're someone who's not extremely chill, and suddenly they're really relaxed and sort of having an easier time dealing with things around them. On the other end, we have sort of unusual confusion, and sedation. So we have excitement or sedation sort of on the opposite end. So basically a change in affect is something that could tip you off about potential drug use. We also have doctor shopping. One thing that if you do have a client who has pain and they're being prescribed an opioid and suddenly they don't want to go to their doctor, maybe because they're not prescribing them enough, or because they're saying, well, it's not treating the pain well enough, or I need to get a new doctor all the time, that could be a sign that they're developing some tolerance to the opioids and might have to be addressed. Also, sudden financial problems and opioid use, if it's outside of medical's context especially, can get really expensive. And so people might suddenly have financial problems. And also physical withdrawal symptoms that we talked about before. But also just a great strategy is sort of bring the family members in on that and sort of talk about things that they've noticed. We shouldn't have to do this alone, so we can sort of have these family members as part of a team, as people who can recognize these abnormal events. Additionally, although signs are kind of observable, really the best strategy for having a client be honest about their substance use is to foster this non-judgmental relationship where they feel like they can approach their community health worker about these things without being judged. Again, major social determinant of prolonged substance abuse is stigma. And so I think that there are some great ways that community health workers can take a step back and sort of not foster a very stigmatized relationship. So a few tips for that are to avoid confrontation. I think oftentimes we're a society that talks a lot about sort of interventions and sort of confronting people about their drug problem and talking about how it's hurt others. And that is one way that it works for some people, but I think that in big part, it's great to avoid confrontation and sort of just understand before we try to jump in. So sort of expressing empathy when they do sort of talk about, here's why I'm using, or something like, yeah, this is how this happened, here's how I got in this situation. Really just expressing empathy with the client and talking about their goals. One thing that I've noticed with clients who use opioids is that most of them have goals for their futures that don't involve opioid use. And a lot of times sort of saying that, okay, well, let's work towards a future where you're sober is not necessarily as effective as saying sort of, let's work towards this goal that you already have. And that doesn't involve you taking opioids, and that'll help them sort of have something to work towards. And incidentally, they can also address their substance abuse. So that's a suggestion sort of fostering a non-judgmental relationship. And when a client does decide that they want to enter treatment, it can be really difficult to find treatment or sort of to decide on which treatment is best. So treatment has a better chance of working when it's consistent with the client's values and goals. So having the client steer this process is definitely helpful. There are areas with few different kinds of treatment for opioid misuse, one of which is supervised detox. I also put a little star next to supervised detox because there isn't very much evidence right now that supervised detox works for opioid addiction. So a lot of times they go in and they have maybe 1 or 2 weeks of not using, and that for like we talked about, having these long-term impacts on the brain and changes to the reward system, just 1 or 2 weeks isn't actually going to be very effective. And there is research that suggests that supervised detox does pose a risk for overdose because they're in there just long enough to sort of lower their tolerance, but not long enough to stave off the cravings. So second, we have these inpatient or residential care. Inpatient, usually longer term than just supervised detox, usually involves a mixture of sort of group therapy and also specialized care. And finally, we have long-term outpatient treatment. And that's sort of emphasizing more of treating addiction like a chronic disease, something that does need treatment on a long-term basis. And so involves check-ins, maybe having a case manager or even a community health worker sort of checking in. So those are a few different options. But because opioid use has these long-term effects on the brain, recovery often requires medication to produce the best outcomes. So when we're talking about medication-assisted treatments, it's one of the most effective methods for treating opioid addiction, but there are a few different kinds of medication-assisted treatment that are available. One that a lot of people have heard of, and that I mentioned earlier, is methadone. And what methadone does is it actually acts like an opioid. So it binds to those same receptors, but it produces a really low euphoric effect compared to a lot of other opioids. And it can also stave off the withdrawal symptoms that help a person slowly reduce their opioid use. So methadone does, it's been shown to be better than a lot of other treatment options. It's more effective. But one thing that's concerning about methadone is that it can be abused. And so people can use more methadone than they're prescribed, or they can use a little bit. They can also give it to people who aren't prescribed methadone. And so Suboxone is another one. Buprenorphine or Suboxone is another medication that addresses some of these concerns. And for that reason, it's growing in popularity because the effects of buprenorphine, they sort of plateau. So once you use a certain amount of it, it won't produce more of the effect. So it sort of reaches an upper limit to how much can be used. And still, it treats those withdrawal symptoms and gives sort of a low level euphoric effect that people crave. And so that's been a really promising addition to the treatment repertoire. Also, we have naltrexone. Naltrexone is really different than those first two because basically what it does, we can see on the right here, it's this third one, and you can see just this line over there that on the bottom of that line is an opioid receptor. And so it just blocks it. And so when you use opioids, they just don't work. They don't attach to the receptors in the brain, so it doesn't produce the same effect. And so naltrexone just blocks the effect of opioids. So it doesn't really treat the withdrawal symptoms. It just makes it so people can't use. So not as popular with people who are looking for treatment, but it is something that's in that treatment repertoire. And it's worth mentioning that just despite supporting evidence, medication-assisted treatment, it is still controversial. So not everyone supports it in the public and some medical providers because some people see it as enabling. It's just substituting one drug for another. But in terms of treatments that have been shown to influence long-term recovery, medication-assisted treatment is one of the better ones that we have. Another thing worth mentioning is just that some clients won't be ready for treatment yet. And that can be a really scary situation for a community health worker, especially someone who's not really sure exactly how to provide the best support, is when a client says, no, I'm using and I'm not going to treatment. So in those situations, we still need to keep those clients safe. And so there are some steps that we can take to do that. One model of doing that is called harm reduction. It focuses on sort of meeting the client where they're at, sort of taking those steps that they're ready to take to reduce the risks associated with substance use. So we can see sort of focusing on sort of respect for persons and collaboration with persons, which again, it can be a little bit scary because we want people to get into treatment. We want them to get well, but ultimately we most of all want to keep them safe. And so one of the biggest risks that we try to reduce for people with opioid use disorder is this risk of overdose. And one thing that I think is really helpful for people around those who are using opioids to know is when they're at heightened risk for overdose. Most people have one of these risk factors when they overdose. Most people don't just overdose based on using one substance as they usually do. So an example is if they have a lower tolerance due to not using for a period of time. So say they were in detox, or they were away with a family member for a while, or they went to jail for a little bit. Afterwards, if they come out and use a drug, they're not going to be able to use as much of it without overdosing. So that's a risk factor. Additionally, mixing opioids with other substances like benzodiazepines, like Xanax, for example, or Ativan, one of those drugs which are commonly prescribed for anxiety, or mixing opioids with alcohol. That plays a huge role in whether or not people overdose. Again, another risk is using alone. If someone is using opioids alone at their house at night, they're not going to have someone to check in with them. And if they do overdose, no one's going to be able to call 911 or respond. If they have a new source, if someone who they were trading opioids with or something, or if their dealer was arrested and they start going to a new source of opioids, that puts them at risk as well. And finally, if they've overdosed in the past, I think an overdose is a time when people should be sort of thinking about treatment, and it's an opportunity to sort of look at the situation and sort of say, okay, we need to take some steps so that this doesn't happen again, because people usually, if fatal overdoses aren't the first time that someone has overdosed. I wanted to mention Naloxone, which you may have heard about in the news, and it's also part of the plan for the national response to the opioid crisis. And it's a medication that can be administered to reverse an opioid overdose. One of the great things about Naloxone is that it can't be abused or used for any other purpose. So its exclusive use is to reduce an overdose. So that's the only thing that it can do. And as of last year, it's available at pharmacies throughout Iowa and in a number of other states, and where they train friends and family members and people who are in a position to reverse an overdose on how to use it. So there have been a lot of interventions using Naloxone that have been quite successful for reducing deaths in communities. Some people feel comfortable using it and some people don't. It is something to be aware of, and maybe to check in with family members and sort of talk about whether they've heard about Naloxone, whether they've considered having Naloxone around the house if they're close to someone who's at risk for an overdose. And I have this quick video that sort of demonstrates a pretty non-traditional response to the opioid crisis. And hopefully everyone's able to hear this. I'm going to try to play it through here.
Wake up, dude. It's a life and death moment. A man overdosing on heroin and meth at a park in Philadelphia. People rushing to his side, including a first responder who administers the life-saving antidote, Narcan.
Go grab another dose.
Shira Kowalski is specially trained to use the nasal spray, something not in her job description. Kowalski is a librarian, one of several in her library trained to use the drug.
When someone's overdosing, a minute or 30 seconds can be life or death.
She normally works with teens at her branch, one of the busiest in the city.
When I decided to become a librarian, I always looked at it from I wanted to serve communities.
The century-old building in the heart of Philadelphia's Kensington neighborhood sits in the middle of McPherson Square Park, known to many as Needle Park.
Kids and the teens have to see this stuff on a regular basis. It's upsetting that this is their normal.
The park is on the front lines of the nation's heroin epidemic, with evidence of battles lost scattered like weeds.
We probably pick up, like, say, with needles, maybe like 50 on up, maybe
50 a day.
Yeah.
Park worker Rafael Feliciano also finds himself helping addicts in the park. His workload has increased dramatically. The city's public health department predicts almost 1,200 opioid deaths in Philadelphia this year, up 32% from last year. And the park surrounding the library has become a focal point.
The opioid crisis, the heroin crisis was knocking at this library's front door. It was camping out on its lawn.
Philadelphia Inquirer columnist Mike Newell started writing about it when he learned of a big increase of people buying, selling, and using in the park, hanging around the library. He was even more shocked to learn how the librarians took matters into their own hands.
They got Narcan training. They started many libraries have fire drills, they have overdose drills.
That's half a dose in one nostril and then half in the other.
And it's working. Since April, Kowalski has revived people who have overdosed 6 times, including this week, just after we spoke with her, jumping out of the library to save that man as we watched. When a library sits at the crossroads of a crisis ravaging its community, services here are a lifesaver.
It's life or death. For a lot of people, it's a second chance.
Steve Patterson, NBC News, Philadelphia.
The mayor's office says that outreach workers have been sent to the neighborhood and that a police mobile command center will be set up in the area soon.
All right. Hopefully people were able to hear that okay. So the reason I wanted to show that video, even though I know most people aren't in central Philadelphia watching this webinar, and they might not be encountering people overdosing in the park every day, but I think it's really interesting to sort of see people taking on new roles and sort of taking on new roles in order to promote safety in their communities and in order to combat this epidemic. So to wrap up and just to go over a few things that we've talked about. So opioid use disorder, it's a medical condition, but not all the contributing factors are medical. We've seen that there are a lot of social determinants as well. And by knowing the environmental factors that contribute to opioid misuse, community health workers can help make the path to recovery a lot easier for their clients. A non-judgmental attitude is critical for helping individuals with substance use disorders and for combating stigma overall. As we've seen, people will encounter stigma, not just from their families and not just from their friends and their community members, they'll encounter it even at the hospital. And so stigma is a huge factor that we can combat. And finally, recovery is a team effort. So engaging family members and loved ones and building up those support systems is an amazing way that community health workers can help people. So thank you so much for listening. I think I can take some questions.
So it looks like we have a question that says, CHWs in my area are not equipped well to do much in the way of treatment, but when they become aware of clients' misuse, what can they do?
Thank you for that. I think it's a great question. I don't think community health workers really should be put in a position where they're asked to provide actual treatment. So especially given how we talked about sort of how intensive treatment for opioid addiction is oftentimes, might involve medication, might not. I think that it's not necessarily something that should be placed on a community health worker. But if they're in a position where they know that their client is misusing opioids, I think that one thing that they can do is sort of connect people to care. And so being really knowledgeable. In my experience, I think I've had clients who they were ready for treatment one day, and then if it didn't work out, the next week they were just like, no, I'm not going to treatment. And so I would say being ready for that day when then they're ready to go to treatment and sort of knowing the resources that are available during that time, I think that's so helpful because you're going to need to be sort of taking the best advantage of these short periods of time where people are ready for treatment. I hope that is helpful.
Another question that we had come in was, what's the typical time period that methadone or Suboxone, sorry, I don't know how to say that word, maybe Suboxone treatment is used?
Oh, I would love to give a solid answer to that. It's varied so much. I've known people who've been on methadone for years and years and years, and I've known clients who were able to stop using after getting on it for a few months. So it really, really has a wide range. I think anecdotally, I've seen Suboxone, sometimes people able to wean off a little bit faster than methadone because it does have that effect that makes it a little bit harder to abuse. That is probably the best I can do on that question, is a period from several months to many, many years.
Thanks. We have another one that came in that said Narcan is another from Naloxone, or is that another kind of overdose drug that can be administered to combat an overdose?
Thank you for clarifying that, because I actually definitely should have mentioned that. Naloxone is an off-brand of Narcan. They're the exact same substance. And so when we talk about Narcan and Naloxone, same medication. There's been a lot of sort of issues with pricing on those drugs. That's been one thing that's been talked about by the president and by a bunch of other politicians, is that Narcan is really expensive and it's actually, the price is increased with overdoses increasing, which seems a little questionable. but they're hoping to lower that price. But yes, Narcan, naloxone, same substance.
A follow-up question on that was, who should be trained in naloxone administration, and where are those trainings being held?
Mm-hmm. So that depends. So family members are a lot of times a great resource if they're living with someone who's using. That's a lot of times who's being targeted. Again, they can also, though, have a hard time getting it with insurance coverage, which I've heard a lot of mixed things. Some people are able to get naloxone really cheap at the pharmacy with their insurance coverage. Some people are asked to pay a pretty heavy copay. So a lot of times I think that family members, so you don't need specialized sort of knowledge. You can be trained within 20 minutes in how to use naloxone. I have naloxone at home just for clients if need be. A lot of times there are harm reduction groups regionally. So if you look up, say, if you're in Des Moines, you could look up maybe Des Moines harm reduction. In Davenport, you could look up maybe Quad Cities harm reduction or something. And a lot of those groups do free naloxone trainings, and those are usually community-based, where you can find them either at a site where they do outreach, or you can call them and they can potentially do a training. But they do these trainings right at pharmacies. And the general rule is anyone who's in a position to assist with an overdose. So if they know someone who could potentially overdose, then they're eligible to receive naloxone. The only people who aren't eligible are people who would say, no, I would never be in a position to assist.
Great. We had another one come in that said, what is the risk to the person who is addicted and uses methadone and or heroin?
So methadone, it's a synthetic opioid that should have it should latch on better to the opioid receptors than heroin. So I believe that they shouldn't feel as much of an effect from the heroin that they use if they're also using methadone, but then the heroin could stay in their system longer, and it could be a risk for an overdose. So you don't want to be using both at the same time. It is a risk for an overdose. And also it's worth saying that you can overdose on methadone. Absolutely. Methadone you can overdose on it like any other opioid. And so that's worth talking about as well. But yeah, so that would be a risky behavior that when they're being prescribed the doctor, that they would have to kind of make that agreement that they're not going to be using other opioids at the same time. It's a little bit easier to sell clients on that because it doesn't work as well when you use heroin. After using methadone, you won't feel as much of the effect of the heroin as much as the methadone. Thank you for that.
And someone asked along the lines of that, is methadone strictly regulated as it must be taken in a pharmacy or a clinic?
Mm-hmm. Yeah, I think typically, I know most people go to a methadone clinic and they'll be there in the morning to take their dose. I'm not sure. I think that there might be an orally administered version that's prescription that can be taken home, but I'm actually not positive on that question. Mm-hmm. Okay. But most people do go to a methadone clinic to get their dose.
Okay. Another question that came in, on average, how long does it take for MAT to take effect? Is the success rate known for MAT?
I don't know if we have one single success rate for MAT. I think it does start right away. And so depending on what the person's tolerance is, their initial dose might start out really high, but they work with the physician or the person at the methadone clinic to decide what the dose is, because it is really important that it starts right away. So that is a great question, because if you had MAT that when they started it was at the dose that they're hoping to sort of taper them off with eventually, then people would not keep using MAT. They would just go back to their drug of choice. And so I think that typically they started out at a dose that's consistent with what their current tolerance is at. So it is supposed to work right away. In terms of whether it's supposed to wean them off right away, not really. It does take some time, and it is a more long-term treatment, which can be a little bit frustrating for people, because oftentimes there are sort of relapses involved in that too, where they stop taking their medication and go back to their drug of choice. In terms of overall success rate, I wish I had a statistic in front of me that would estimate that, but I know that it does vary. But it is, I think I've seen studies where it's compared to just people who receive just general counseling or outpatient therapy without medication-assisted treatment, and it does provide better long-term recovery outcomes than that.
Okay. thank you.
Sure.
We had another one come in that said, what can we do as public health professionals to educate and prevent opioid use in rural communities? What is the preventative target audience? Can you recommend any evidence-based programs being used at the local or state level?
Well, a lot of the ones that I've seen with community health workers anyway, or one that I've seen with community health workers is sort of providing peer recovery specialists. And so those are targeting people who have maybe gone to the emergency room already. But I think a great opportunity would sort of be to talk about sort of the dangers of sort of sharing opioids that you are prescribed. And that you would think would be sort of I will say a lot of the interventions for opioid misuse target addicts. They target people who are addicted to drugs. And I think that maybe an interesting audience to explore would be people who are prescribed opioids very legitimately. So and to talk not just about misusing, but also about sort of sharing drugs and how dangerous that can be for their communities. That's one thing that comes to mind.
Thank you. So we've got a lot of great questions coming in.
Okay.
I'm trying to keep up with them.
Okay.
Another one is, with the opioid epidemic and the demand for an opioid detox centers becoming so prevalent,
Yes.
do you or will community health workers see a rise in training for this kind of detox center?
Oh God, I hope so. I think it's interesting because a lot of times treatment for substance use, we talked about a lot of these medical causes, but it's lumped in a lot with mental health. And Iowa, as we know, has a huge shortage of facilities for mental health, where they're already having a hard time getting people with beds. So I hope so. There's been some funding that's come in for people who can commit to being care providers for people with substance use disorders. That was, I think, was in 2016. I think it was the last year of the Obama administration. They authorized $1 billion towards going to the opioid epidemic. And so that provided a lot of funding for federal funding, which is kind of rare for treatment options. So I'm hoping that more facilities will be built, and I hope that more professionals are trained and everything. I even just like hearing all these questions and everything, it's something that people are interested in and something that people care a lot about. Again, so many people know someone who struggled with an addiction. And so I hope that more people choose that as sort of a career path as well, as something that they're looking into.
Great. Well, I see that we're at about 1 p.m. right now. I'm going to see if there's one more question that might be answered quickly. It looks like there's a lot of questions for resources on here. So I think we can collect the questions and potentially add some resources to the email that we sent out with the link to the webinar. But I think, all these questions seem like they'll take a little bit longer, and we're already at 1.
Okay. Yeah.
So if you want to go ahead and say thanks to everyone for joining us today.
Yeah, thank you so much. I really enjoyed talking about this, and I'm sorry that I'm not able to get to all the questions. I'm glad that so many people are so interested in this. So thank you so much.